Hi, everybody. I know it's getting late on the second day of Summit, and everybody's excited to go and have some drinks and go to the opening party, but I'm really excited to be up here with these guys who, I was going to say, look how tired they are because of how much they're doing, but they all look really good. So these guys, a lot of you here are entrepreneurs. You started your own DPC practice. It is extremely hard. These guys have decided to start their own health plans. They're just Buca's not working. Let's start something from scratch. And so all of them are also at different stages of incorporating DPC into their plans. And I wanted to bring them up to kind of show you the people behind those plans, show you what's important to them, and just kind of talk to them about how it's working for them. So I'll let you kind of go down the line and introduce yourselves. Mike, do you want to start and tell us a little bit about Excel Health Plans?
Yeah, thanks, Beth. Really appreciate being here today. Very excited. I'm Mike Patton, president of XL Health Plans, founder, and my mom is actually a primary care provider. I actually ran into somebody who was in her residency class last night at the Hint dinner, so that was pretty awesome. But my foray into healthcare comes from working in a primary care office and really understanding the problem with healthcare inflation because someone had a pacemaker put in that cost $600,000 because of a medical error. The pacemaker started falling off. They had to reattach. A gentleman caught an infection, was in there for a number of weeks. So I was really inspired to do something about healthcare by that. And what I did learn while working at my mom's primary care clinic is that people really lean on their primary care provider to understand where to go and what to do for all things healthcare. Did referrals there. So what I learned was, people would do whatever primary care providers suggested in terms of a referral process. And fast forward to now, did a lot of work as a benefits consultant, and then started XL Health Plans because I thought that a product was needed in order to scale solutions. I'm a member of Health Rosetta, and we're the largest community-owned health plan in conjunction with Health Rosetta. And I thought a wholesaled product was needed to scale these types of solutions. And DPC is really an important part of that because our members are able to be redirected to high-quality, low-cost facilities at a much higher rate by primary care providers than they are by the plan itself. People just respond much better to physicians and nurses than they do to an insurance plan attempting to tell them what to do.
Yeah, that's really hard to believe, but thanks for that, Mike. Nick, do you want to tell us a little bit about who you are and what you're doing with Decent?
Yeah, I'm Nick Soman. I'm co-founder and CEO of Decent. And I'm feeling a little insecure to be up here because some of you know me from the last few years of being here. And we've been working to try to figure this out and build health plans around DPC. And first, the feds kicked my ass. And they changed the rules so self-employed people couldn't participate. And then we had a whole new model. And our executive sponsor at a big carrier partner got fired by his board right before we did a national launch. So I'm conscious that I've come up here and told a big story and not delivered what I want to deliver for you yet. And I was talking to my friend Ben Aiken about this last night. I told him I was feeling insecure, and he said, listen, buddy, we are all entrepreneurs, everybody who's here. And this is hard as heck. And it made me feel a lot better. So thank you. I'm doing this because I'm the only one in my family that's not a primary care doctor. And the reason I'm not one is because my mom would tell me that this is the worst time to become a primary care doctor in the last 50 years because of the rise of managed care. And I was about 12 years old when my dad came home. And at that time, after 30 years in primary care, he'd become the chief medical executive of Group Health Cooperative, which is a 650,000 member HMO that was in the Pacific Northwest. Then it sold to Kaiser. And I remember he's pretty soft-spoken. And he sat down at our dinner table and he said, I just don't think my counterpart, who's a gentleman named Scott Armstrong, cares about the patient. And I'm a big talker. My dad is not. It hit me pretty hard. I decided to go into tech instead. I lost my mom about 10 months ago, and I see an opportunity to build something she'd be proud of.
Okay. And Jason, you want to tell us about Clearwater?
Yeah, so Jason Sherman, CEO, co-founder of Clearwater. Such an honor to be here today with you and these amazing gentlemen. Clearwater was founded about 6 years ago from an experience I had as a consultant working with a very large TPA who had just seen 6,000 people file for bankruptcy because they had denied claims that were on the plan. And I thought I'd be walking in with people losing sleep, pulling their hair out, having so much shame. I asked the CEO, what's your biggest stress point right now? And he said, I've yet been able to buy the jet I've been dreaming of. And I knew the system was broken. So we started Clearwater with that intent to say we want to fix this out-of-pocket problem. 60% of all bankruptcies are due to the healthcare costs. 90% of those are people that have insurance. So we built Clearwater that fully to solve that problem with traditional plans, with non-traditional plans. We do major medical. We have our own health share. We do vision, dental, life, critical illness, and accident, all with the intent of making the out-of-pocket costs come down much lower.
Yeah.
My experience with DPC, I have a very good friend who works for a large DPC in the Northeast. He called me 5 years ago looking for a solution because they were trying to sell memberships and had too many people that were paying $2,000 a month for Blue Cross insurance, and they couldn't get people to do both. So he was looking for a way we could build a plan that could just take care of the catastrophic part of the needs, and then the direct primary care could take care of the preventative.
Yeah. Awesome. So you guys all have stories about how primary care has impacted you or been part of your life. And Mike, I heard you say that primary care is important for your plans because you've got a new type of plan, and having primary care be the front door, it makes it a lot easier on your members than having insurance be the front door, and differentiates it. What are the other reasons that you wanted to incorporate such a strong primary care benefit into your plans?
So obviously, from the first standpoint, cost is always what we're looking for. So the biggest drivers to cost are expensive claims, and we have solutions built into the plan that look to lower healthcare costs. But it's not just about cost. The thing is that there's actually an inverse relationship between cost and quality in healthcare for the most part. So Dr. Smith, if you guys are familiar at Surgery Center of Oklahoma, they've only had one infection in the last 10 years. And you're talking tens of thousands of procedures, versus your average hospital in the U.S. has an infection rate of somewhere between 2% and 4%. So, and hospitals are where you go get orthopedic procedures that are the most expensive. Ambulatory ASCs tend to be much cheaper through our plans. So we're allowing members to get higher quality health care, make sure they're not, exposing themselves to greater risk of infection or worse conditions. One of our vendors is called Benefit Smart. They're a cancer treatment program that typically contracts with independent cancer facilities, over 1,300 across the U.S., and they actually embed therapy for the families of all of the members who have cancer as part of the clinical protocol, because taking care of the members and their families and their well-being is actually a part of delivering that health care. And if you look at, your average cancer claim in the U.S., probably over $100,000 a year per person, like how little is it for us to invest a couple $1,000s in therapy in their families? So the patient is really important to us, and that member experience is critical, and that's where the alignment with direct primary comes in for Excel.
Jason or Nick, you want to take that question?
Yeah. How many people flew here? How many people bought on United.com? How many people bought on Kayak? Or an aggregator of some kind? It's a higher number, right? So my mom was a really great primary care doctor, and she'd see you for 8 minutes, and then she was contractually obligated by Group Health Cooperative to refer you into a specialist in the same HMO who would overcharge you, because that's how the HMO makes money. What's going on in our health system is criminal. It's absolutely fixable. About 90% of the cost in an employer-sponsored health plan is on steerable care. It's not the primary care. It's not the emergency care. You can't eliminate it, but if you have a doctor that has good data about where to send people to get great quality that doesn't break the bank, then members are going to listen. And I think we're going to change the question from does DPC pay to itself to if you have a model where the doctor can tell the member where to go and it's not a blood oath with a specific health system, we're going to prove that we can save people so much money that the question is, can you afford to not have an independent direct primary care doctor at the heart of your health plan? And I care about experience, and I've been a DPC customer for the last 5 years, but until we either gain the political wherewithal as a country to get to single payer, which I will argue myself toward, blue in the face, we're not going to get there. Or we work with y'all to prove out a model that is better, but it also has to be cheaper. we're wasting our fucking time.
Jason?
That's a very easy way to follow. We are very passionate about the DPC relationships for similar reasons. We have three core problems it solves for us. 92% of all of our claims on our traditional major medical plans have to do with primary care. From the use of it, which we have no control of if we're working with the PHGS network, which is a train wreck if you ever work with that, but the members blame us when the experience is bad. When we have members that have a direct primary care and they're showing it for the catastrophic part of our plan, they're coming in, one, as raving fans of their current experience, and two, they get much, much, much better care. So much so that we charge 30% less and make them pay $0 out of pocket if they get a surgery at a facility that's been recommended by a direct primary care doctor. So it brings down our out-of-pocket costs, brings down our claims, and radically increases the member satisfaction.
That's great.
We like it because it's better.
It's an easy crowd here, Nick. Yeah. So one of the things that I know you're familiar with, I know all of you are familiar with this, kind of having your own health plans, is operational challenges. So kind of like any piece of the puzzle, you're putting different pieces together to create this one experience for your members, and you're not, I mean, you'd say you're not a United, you're not a Blue Cross, as if they're doing it well. They're not doing it very well, but you're starting it from scratch, and so you're putting everything together, and you're putting it on platforms that may be new, and you're doing these things for the first time in a lot of cases. The same way DPCs new DPCs may be doing things for the first time. So what operational challenges have you encountered when working with DPCs, and kind of like what do you see as a path forward there to make that relationship go more smoothly so that we can get more DPCs embedded in solutions that are kind of like overall and make sense for employers?
Yeah, so that's an interesting question, Beth. One of the things that's been a struggle for DPC with us at Excel is, we have a very specific recipe on how we're referring all of our members, because we attempt to replicate, because most employers in general, as we were trying to scale this, it's difficult to teach benefits consultants how to sell DPC on top of the health insurance plan, because if they present it side by side with a lower cost plan, the employer is just going to say, let me buy the cheaper plan. So that's kind of the first problem is, so the plan is built to be able to do a portion of that steerage on its own, assuming there is no DPC. So the most challenging part is actually integrating the different steerage patterns with your direct primary care provider. So teaching a direct primary care provider in Des Moines, Iowa, okay, we need to refer our members to this outpatient orthopedic surgery center. We need to go to this set of cancer facilities. We need to send people to this J-code infusion-based facility. And then in different markets, that entire pattern changes. So that can become an operational challenge for both us, as well as setting up our independent third-party administrators to administer claims from those different facilities. And then a lot of these DPCs will manually bill for some procedures like lab work, or sometimes they dispense some types of pharmacies in-house. So having multiple administrators, multiple PBMs, and then having multiple ways to put that dollars in the bank and set up those billing arrangements, that can definitely be a challenge.
Yeah. Do you ever get DPCs pushing back on your network and saying, I don't work with that guy, or, DPCs have a lot of relationships in their home community about who they like to work with, who have been good to their members. So what do you do when that happens?
Yeah, so, that's definitely happened. So where DPCs have relationships with members, and, when we get started, sometimes if there is locations available on like our tech platform where referrals are created, we definitely prefer that. And a lot of times that's more because it's much easier for the administrator to send and receive the claims on that platform. And the DPC will say, oh, hey, this other surgeon can match those pricing, but there isn't a mechanism to create that claims payment. Mm-hmm. So that creates additional complexity. And sometimes it's difficult for the insurance plan to explain to the provider, hey, if we create this additional complexity, the likelihood of a problem goes up significantly, and then the likelihood of the member getting all pissed off because, there was some issue with the claim not being paid correctly goes up. So we're always looking to avoid those problems, and there's definitely some ebb and flow with DPCs in doing that.
Yeah. Nick, do you want to take a stab at that one? Operational challenges?
Proving that we have a right to exist. I'll elaborate. This is not a new way of doing primary care. And I think people forget this because insurance was invented as a financing mechanism several decades ago so that teachers who went bankrupt would stop hurting the hospital bottom line. And I have had to do a lot of soul searching about, well, what is our right to exist? Because we aren't physicians, we aren't providers, we aren't patients. I feel like I'm always arguing against myself up here. Is my technical co-founder Richard in the audience? There he is, the guy in the red back there. He's super cool. And I remember when I met Richard about 12 years ago, I was a hubristic, loud, business-driven guy, and my actual belief was, I just need a tech guy to build my great idea. And he remembers that I was like this. And I see people, not people on this stage, but people come in and go, well, I've got a great business idea. All I need is some doctors to execute my great medical business idea. And I would advise you to run away screaming from those people. I now am advising a bunch of technical folks like Richard, and what I will tell them, and again, negotiating against myself, I'll say if somebody hasn't raised money before, and they're just coming to you with an idea, they haven't proven anything. Go find somebody that can prove that they can bring something to the table. So for me, I need to prove my value to you, and I think the right way to do that is to bring you members and make sure you're taking care of them the way you want to be. And figuring that out is the thing that's going to allow us to build trust with each other, that's going to make this model work better. And that trust bit, I mean, that's the problem with healthcare, isn't it? That's the thing that's hardest to establish. You have it with the member. We have no right to ask for it without doing the work to earn it. And that's the hardest challenge I face.
No.
For us, I wouldn't say we have any operational issues I'm aware of other than what Hint Connect is solving for us, which is having traditionally two separate plans. Our HealthShare memberships are over here, your DPC memberships are over here, and a lot of times there's not connection. Mm-hmm. So being able to have one plan on one platform where people see it that way allows us to refer more people to use DPC memberships, and hopefully vice versa. We haven't launched it yet, but as we launch our major medical plan and replace our PHCS network with DPC facilities through Hint Connect, that solves a really big problem for us on our care coordination, because our care coordinators are not doctors always. So they may be looking for the best facility with the best outcomes at the lowest price, but if they could work more in conjunction with the DPC doctors, we could really provide a better experience on quality and cost. So as we connect those plans and have them be more uniformed and work more closely, I think we can provide better outcomes.
Yeah. So I think we have time for one more question, and I'd just like to throw it out to all three of you. Briefly, what do you want DPCs to know about working with your organizations?
I would say the thing that DPC should know is that the most difficult part of getting integrated health plans is educating and working with aligned benefits consultants, because it's actually very difficult if you're working with a benefits consultant who doesn't believe in the mission and healthcare in this model. One, they're probably financially incentivized by the carriers to not sell something that aligns with you. And secondarily, it takes someone who's committed to the mission to help educate the group in a manner to understand the value prop that they need to invest up front in primary care to help drive their bottom line savings over 2 to 3 years. This is something companies do all the time across all industries, and they understand, but typically on their line item expense number 2 or 3, they don't even have a plan on that. So you need a benefits consultant who understands that value prop in order to effectively scale. And if you're not working with those consultants, that could have a huge effect on why it's difficult for you to engage. And we at Excel work with over 170 consultants across the country. So we're happy to help introduce you to some of the people that we work with who know how to sell this.
I agree with that take. It is hard to find aligned benefits consultants. I moved to San Francisco a decade ago and change, and my first roommate was my high school friend Kathy Moore, and she was and is an elementary school teacher. And I remember how hard she worked because she wanted to be a teacher. She was paying out of pocket to buy her students supplies. She was showing up at 4:30 in the morning sometimes because she wasn't getting the school district support that she needed, and she was being punished for her passion, for what she wanted to do. And I'm sharing this with you because sometimes when I see DPCs, especially DPCs who are getting involved in a plan that's been pulled together, sometimes sort of sloppily around them, I see you picking up the slack and going, all right, well, why are half of you telling me that it's harder to work with an employer customer than your individual customer? Part of it is because there's all this infrastructure that has not been built. There's all this empathy that a lot of folks don't have for the fact that it's going to fall on you, because at the end of the day, you made this choice to do what you do. And we're trying to fix that. And if I can fix that, we'll build something big. But if I can't fix that, we don't deserve to exist. I want you to know my email, which is nick@decent.com. And I want you to help me figure it out, because we aren't at a place that I could just say, this is the solution. But this will not take off if it continues to be so difficult to scale, if it continues to be so difficult to convince your friend to come over against the will of his mortgage and join your practice. We have to fix some of these things, and that's what Decent, I think, is focused on trying to do, to make it easier so you're not just being abused for your passion.
Thanks, Nick. Jason, briefly.
Easy to just say ditto.
Yeah.
Everything they just said. Yeah, I would just say we're all three very similar here in we're trying to solve a broken problem, all of us together, and know that we are on the same team. We want to help your practice grow. We want to make your patients stay with your practice and be very excited. We want to help evangelize people to see how powerful DPC can be, and we're in this together. Let's go change the healthcare system in America together.
Yeah. Awesome. Well, I think we have time for a few questions. If anyone in the audience has questions. Looks like Dr. Moore up here has one.
Thanks. Thank you guys for sharing all this. I had a question, see if you can help me with it. So I have a broker who I think has everything together. He's been in the DPC space for a while. So he's also a patient of mine, and he knows that we do a really good job. But he's built his own health plan, and he wants to integrate my DPC into that health plan so that everybody that he sells that to would automatically be eligible for a membership. And I charge $80 a month per member, and we have 35 companies we work with. He wants me to go down. He actually asked for $30 per employee per month.
No.
Yeah, and so I'm kicking around the number 45. But here's where you have to help me. Right. So I feel like I'm getting screwed. But I'm not. I haven't signed anything, so I'm asking for some wisdom on both sides. Because the other part of that is, we like to add free things to our $80 a month, and labs, and say, hey, you get your annual labs for free with this, and try to give as much as we can. That has gotten us into a little bit of financial trouble. So we're very idealistic, altruistic people, and that gets me in trouble routinely. And I don't want to make a mistake here. So I want to know, if he says to me that I can bill all my incidentals to the TPA that he has worked out, which is Lucent, I think it's Lucent, and that I would just send all those bills to Lucent, they would pay without a lot of question, and then so it would kind of work on averages where that could work out to be good math. The math is hard for me. So can you help me understand, how is he screwing me, or is this working for both of us in a good way? And I think you guys are the ones to answer that.
Yes, he's screwing you, and no, you shouldn't do it.
I just wanted to ask a clarifying question. Is he saying that he's charging the group 30 PEPM as his fee? Because that is like about standard nationwide broker consulting fees. Or does he want 30 fee on top of his own fee out of your cut? Yeah, that's pretty steep. And I would steer clear of that.
I actually don't know his cut.
Yeah.
Okay.
He's just saying instead of $80 a month, 45, based on having everybody involved, but not everybody participating.
Hold on. So he wants 30 of your 80. Is that what you're saying? Or he wants you to cut your fee to 45?
He wants me to cut my fee to 45.
I mean,
Less pricing plan to sell is what it is.
that actually makes a lot of sense. So The reason for that is from a stop loss perspective. You're never going to get a stop loss carrier, or at least in my experience, who's going to discount DPC proportionally to the effect that it costs right now. There's not a carrier in the market who's going to say, if an average health plan in the U.S. is 500, let's just use an even number, $500. You can get most stop loss carriers to maybe give you probably top line a 10% discount on that. So you're probably looking at a 50 PEPM discount. I mean, from what I see, DPC nationwide, it's probably pushing 100 is normal average. So you're not going to get what he's thinking is you'll sell a lot more of this if you get your price to a point where I can get my stop loss carrier to discount it, and I can basically tell the employer that it's free. So that is a reasonable idea. If you can push some of the money that you would charge up front over to being claims and reduce the net upfront cost, you're basically telling the client that this is effectively a free benefit, and it will be easier for him to convince employers to buy your plan. I would agree with that.
I would say to the point before that the Peakman and PHP and Strata guys were making up here, then you will be a free benefit, and you're not, people expect the value of what they get. So I would say, let's talk about that more.
Yeah, we
Get the
have
resources here.
different opinions here, but I would say you should get $80, period.
Yeah.
They should figure out how to get the rest.
Yeah.
You can solve the problem the same way. Why should you take that cut? There's a TPA, there's a stop loss carrier, there's a broker, there's all kind of fees. Find it there. And if the broker can't sell the value of a little bit more money for the exceptional service, then you're working with the wrong broker.
Yeah.
I think that's right, and I would add two things to it. One of them is some of you are so frustrated by the challenge of finding a broker that's values aligned and gets the value of DPC that you're becoming brokers, which, God, I got to imagine how tough that decision must have been for you. That is something people are doing. A real smart one from Kansas last night. I said, well, how do you think about this maybe an issue of a conflict of interest? And he said, it is a conflict of interest, and it's a disclosed conflict of interest, because I tell people that's what's happening, unlike certain unethical brokers that'll take a $7 kickback from the PBM and not even mention it. And so that's one path that people are going down. I think he's either unethical or stupid. And if he's stupid, it's because he's using you in the plan wrong in a way that's not going to reduce, the costs enough to cover it. And I guess just an observation from being in business for a while, it's the people that always come and try to give you that sort of a screw job that never drive any goddamn business. So find somebody who knows how to do it.
All right, we're going to wrap up on that nugget of wisdom. Thanks for listening to the session. Thank you guys so much for being up here. Really a lot of good content. So.